Right, I think we may as well make a start. We've got 62 of us here. You're still joining. Could I just ask if you're able to, if you could go on mute, because we've got quite a lot of people on the call, a reasonable amount of background noise. Feel free to come off mute.
Tom, has there been engagement with the international providers?
I'll put you on mute if I can do, and unmute you selectively. Maybe that's probably the easiest option. Thank you all. And thank you to everyone who's hitting admit. That's really appreciated. It's really helpful. This session is to provide an intro to the model health system with an emphasis on the population health and right care section. I'm Alex Porter. I'm one of the analytical leads that works in the Midlands region. I work on service improvement and I support the right care improvement partners and systems in the Midlands region. I'm joined by Bryn, who I think is on the line. Bryn, can you just say hello?
Yep. Hi, everyone.
Right.
To do an intro now, Alex?
I'll let you do it. You don't do it now? Just quick say hello.
Yes. So I work within the improvement analytics team within the improvement directorate in NHS and lead the right care and population health part of that team. And we're busy incorporating all of our information from the right care packs into model health system.
Thank you, Bryn. I'll just finally stopped all the beeping noise as people join, which is good. The goal of today is to, like I said, talk about this population health section. Bryn's shown some really new and exciting additions to the system, which is really good. So hopefully to take that through. A lot of these changes launched today, so hopefully they'll be new and interesting to you. You may have been on one of these before, so hopefully it's going to be interesting and new stuff to you. If it's new, please do ask questions. If you're able to, could you go to a separate browser if you can without losing the Teams meeting to menti.com and type in the code 5074 4800. I'd like to do a quick couple of questions just to get an idea of who's joined, because there's 92 of us here. We have to know kind of what your interests are and where you're from before we start. Thank you for those who've gone on mute. If any problems getting access, I'll kind of keeping an eye on my email and the chat function, so please do put questions in there or shout up if there's anything you want help with. I'll try and update as I can when it talks. First question, could you tell us what region you're from, please? Oh, it's working. Oh, predominantly Midlands. I was wondering which audience I'd get. I saw a lot of outside people. From as far as Cornwall sign up, so great, okay, so that's predominantly Midlands. 50 people have responded. Last couple of chances for people who want to answer. Still going up 56. I'll stop there, 56, let's give them a look at the sample. Question 2, if you could tell us, what is your role? I'm interested whether you're kind of analyst, commissioning, clinical. What is it about your role that's brought you here? If you can tell me. Nice to see analyst in the centre of the box there. That's good. That's what I like to see. Some directors, some leads or clinical leads, population health elements, somebody's kidney, performance data, network people, improvement, commissioning, analytical focus. Good. That's okay. You're kind of in the right sort of place. What we're kind of hoping for. So Thank you. Oh, it's very busy. Anything else into spot performance improvement, finance managers, big analyst in the middle. That's good. That's helpful. Final question. Could you let us know what you would like to learn from this session, and we'll try and tailor it and tweak our agenda as we go along. Yeah, latest things, best practice. We can show you what we think might be good practice. I don't know if it counts as best practice, but we can try. Jargon busting, oh, that's a good one. Please do shout up if we use too much terminology that's not familiar. Transformation, model hospital. I should have done this in the list view. Far too much information for a word cloud. How to support colleagues, benchmarking, available data is kind of the big one, and yeah, improvements, benchmarking. How do we stop this thing so I can read it? Links to county councils. That's an interesting comment. So this is very much focused on acute trusts and STPs, but maybe we can talk to you briefly about sort of our primary care network, right care packs, improvements and new stuff, evidence. Okay, so that's helpful, I think. Bryn, does that help kind of set the sort of scene for what sort of things we're looking for?
Yeah, that's really helpful. Thank you, Alex and everyone.
So that is really useful. So we're kind of suspecting that some of that feedback might be the question. Bryn, his team and my team both support kind of a range of packs. Model health system is something we're really putting a lot of energy and effort into to be something we can easily use this year, as that's what model health system is focused today. But we might kind of come back and focus on some of the other products that we can access, such as the Where to Look packs, primary care network and focus packs that are still out there and still useful if you've used them previously. We've just updated a number of these for 1920 data, so the latest reliable pre-COVID benchmarking. If you do need any help with any of that, please do get in touch with myself and I'll kind of link you to my team, or you can join. We've got a Midlands NHS Futures network where we make most of these packs and benchmarking available. So if you want to join there, you'll get a lot more information. But Bryn, I think that's my cue to hand over to you. So I'll stop sharing the screen and you can take over.
Yeah, great. Thanks a lot, Alex. And yeah, I will start sharing. And apologies in advance if my dog starts barking. The next door neighbours' builders are driving her a bit crazy. So.
I just love the fact we can do a presentation to 100+ people without leaving our house. It's so much easier than any other way.
Okay, so yeah, I'll start sort of with the beginning. So for those that you aren't already familiar, so Model Health System is an expansion of Model Hospital, which a lot more of you may be familiar with. So you may already have a login, and it may look something like this that you're used to seeing, with obviously the blue colour scheme. So this is the Model Hospital view, and has obviously been around for a long time, covering a wide range of largely provider-based information. And yeah, there's also, sorry, wrong button. There's also a range of, so you can view that by acute specialist, ambulance, community, and mental health. They've all been there for a while, and but the system one is relatively new. And yeah, so if you click on that and select an STP, then it will take you through into Model Health System. So everything's all in the same platform, and yeah, you'll see the colour scheme change, and you'll know where you are. So there's yeah, quite a lot of different ways to navigate around and to that you may want to sort of go in and explore things depending on sort of what angle you're coming from. So I'll just quickly cover cover a couple of those. So we've got these opportunities for improvement, which is sort of the first thing you see. You can see that 3 of them come up straight away. You can either expand or close those down. 3 of them come up here, so you can see we've got bed days, opportunities from day case surgery rates, from length of stay, and from theatres, from the theatres collection. But if you click onto that button, then you can take to that page, which will give a wide range of different opportunities. So say we've got readmissions, we've got length of stay, we've got day case rates, and then down at the bottom we've got some of the population-based, right care-based ones. So looking at non-elective bed days there per 100,000 population. So yeah, I might come back to that later, or indeed if people, sorry, I should have said at the start, please do use the chat function just to ask, or raise your hand just to ask any questions. If there's anything you'd like me to show in a bit more detail, please do so. And Alex, if you could keep an eye on that for me, that would be helpful.
Of course.
So that way in, and then there's these highlighted metrics, which again you can just click to expand, and this will show where your system is RAG rated on so some of the key metrics from the various different compartments. So yeah, you can see there's a range of things come up, and again you can click into that to see view all highlighted metrics. I won't go through that now, but yeah, you can see there's a wide range of things, and over here it tells you, yeah, there's 10 coming from the gynecology compartment, 6 coming from orthopedic surgery, etc. So yeah, it will largely, it'll depend partly on personal preference and partly on what exactly it is you're looking to explore within model health system hospital. There's also search functionality. You can have this browse view as well. So yeah, there's various different ways to navigate around, or you can just click onto the sort of home page, and then there's all these different lenses. So opportunities for improvement, highlighted metrics, policy priorities, people. Then there's acute hospital services, which has a range of different compartments in there. Again, for those that are familiar with model hospital, you'll see that this is a much smaller list. So we haven't yet transferred everything over. So there's only a relatively small proportion of those that we've aggregated up to STP ICS level to include the system view. And then again, we've got the support services and care settings. So hopefully that gives a sort of flavour for how the different ways that you can navigate around. But for most of this, I'll focus on the population health compartment. But as I say, please do use the chat box if there's anything else that you'd particularly like to see.
We've had a couple of questions around mental health, learning disabilities, and autism, and then on maternity. So we'll come back to those at the end. We'll probably go back and show you some mental health trusts. So someone's asked how to get into the model health system from the model hospital. So could you just show the switch on the top to choose? That'd be really useful to start.
So did you say if you're already in model hospital?
Yeah, how to switch between.
Yeah, so there's underneath your username, there's a change and next to your organization that you're logged in as, there's a change organization. So if you click onto that, then you can either search, or you can you can filter, and the filter by STP ICS. For me, the whole list will come up because I've obviously got a national user. To be honest, I'm not sure if you're a local user, whether that will be the full list or just your own. But yeah, you'll be able to find your STP on the list and select select that, and then if I select Birmingham, I'll take you through into the system part of the platform. Any other questions, Alex?
Just going to get a regional view. The answer's no at the moment. It's a bit tricky, but if you want to chat after, we can give me a call if a particular purpose you want that for. We can do it in certain ways. So some of the charts you can create show regional pairs. So for particular metrics, you can kind of try and create a regional view, but it's difficult to get a regional aggregation of the opportunities at the moment.
Yeah, that's right, and that is something, yeah, that Alex and others have requested. So yeah, we can certainly note that again as being a request from this workshop and feed that in.
So I'll make a note to come back to the maternity and mental health parts, but I'll let you crack on, Bryn.
Great, thank you. Okay, so this is the population health compartment. So yeah, each compartment has a series of headline indicators which are selected, which are shown on the main part of the screen over on the right hand side in the center. Normally, yeah, that's sort of a case of selecting the top maybe 6 to 10 key metrics from a compartment. It's a bit more tricky because of the breadth of the population health compartment covering so many different conditions. So what we've done at the moment, but again, this is still in alpha testing, so feedback always appreciated. We've selected non-elective, so total bed days for each of the programme categories, and yeah, we've got 2 views there. So we, because of COVID, and we can possibly come back to this in more detail, but we've for the benchmarking view, we're just showing the 2019 data. Obviously, more recent data is available, but is very much impacted. Different parts of the country have been very differently impacted by COVID, so that makes the comparisons to the similar 10 peers, which sort of underpins all of this, very difficult. So what we've done is to take that pre-COVID position, but then we've got time series charts which show basically the COVID recovery essentially. So this is the cancer total elective and non-elective bed days, and seems to be loading quite slowly, which doesn't bode well. But what we've got is the number of bed days in the last 3 months, and that's divided through by the equivalent period in the pre-COVID period. So I think we've currently got November to February. So November to February 2020 to 21 compared to November to February 2019 to 20. That doesn't seem to be loading, so I'll just go back into that one and see if it will load a different way. So yeah, you can see the charts there in thumbnail view. So there we go. So we've got that as a rolling 3-month period. So you can see there we've got a time series. So it's that first data point here is April to June 2020 compared to April to June 2019, and then yeah, that just moves on 1 month each time. So we've then got May to July, June to August, etc. So yeah, you can see obviously increased quite a lot in terms of activity from the sort of first peak when everything was sort of closed down to deal with the first wave of COVID, sort of steadily rising towards November, and then it's been sort of fairly flat from there, or falling slightly as we had that wave over Christmas. So yeah, as I say, sort of COVID does make those comparisons difficult, so that's why we've taken that approach. So intention being that those 2 indicators will very much be looked at alongside each other. I'll just pause there, Alex, if there's any questions.
just find the unmute button. The only question is about specialised commissioning being included in this one. So these indicators include all activity for the STP question, so all the population for all kind of settings. So it does include specialised commissioning within that. I'm not sure if there's any more specialised specific data on the model health system, the model hospital side.
So that's something that's coming soon. Actually, yeah, we've got the quality surveillance indicators. I'm not quite sure on the timelines, but they are in the process of being added. But yeah, as you say, Alex, this does cover everything, although in terms of specialized commissioning, yeah, whether the provider or commissioning route, but it won't capture all elements of activity. So for example, it doesn't have the unbundled high cost drugs or critical care. So yeah, it's not complete coverage, but yeah, it doesn't sort of strip out on the basis of specialized commissioning or not.
We've got a bit of a discussion going on the chat about mental health trusts data being available in the STP view. I don't think we get any mental health boxes at the STP level. Is that the case when we browse at the next level up, Bryn? Sorry, we've gone back in our level.
Sorry, say that again, Alex.
So at the if we go up a level to the STP level view, do we have any mental health sections aggregated up by STP, or is it all?
Yes, we do. So they're in the process of being added. So yeah, so not live yet. Well, rather, I think the lens has gone live, but it's not showing up because there isn't any data being sent live yet. But if I just go back to select a mental health trust, and we'll do. You'll see we've got this mental health services lens within there. So all of these compartments are being aggregated up to STP level. So taking that mental health provider data being aggregated up on the basis of the providers within the STP. But we're also adding some population views to that as well. So we're adding that on a pathway basis. So we've got one for common mental health disorders in development, which is largely based on the IAPT data, and then also severe mental illness and dementia. And then we'll also be adding something on children's and eating disorders as well in a bit further down the line. So yeah, that's in the coming soon box.
Thank you. So let's make you jump around a bit there.
That's fine.
And probably back to the agenda, we've had a question around kind of how do we follow through the metrics. So it's probably a good opportunity to get back into the population health section. So how would we go from, say, an activity on MSK by programme and get down to, say, speciality level or some of the kind of more interesting levels?
Yeah. Good question. Yeah, so hopefully I will show. Yeah, there's as I say, a few different ways that you might want to go down that route. But yeah, so one route might be on this headline in indicator section. So, for example, for Birmingham and Solihull, the blue and black isn't the best view perhaps for these charts, but if I can just scroll down and pick one where actually there doesn't necessarily seem to be one where Birmingham's that high in terms of bed days, but that would be one way to do that, where you could see that Birmingham and Solihull is showing up as having a high number of bed days. So for example, if you did see that in the cancer and tumours charts, then you could go back out to the main page, and there's a cancer compartment. So then you could explore that in more detail, and then similarly there's other compartments for ophthalmology, orthopedic surgery, urology and gynecology. So that would certainly be one way to sort of, yeah, if you wanted to dive straight into one of those conditions. Alternatively, yeah, you could be reviewing it along these subcompartments that we've got here, which we've sort of tried to base around the pathway. We've obviously got some gaps. That's not a complete pathway, but yeah, it's probably useful if I go through that as a sort of different way to view that. And then also one of the things that we are working on is a dashboard within Viewpoint, the Viewpoint system, which some of you may be familiar with. And we'll be able to do a sort of what's called a pass-through from this model health system into Viewpoint. So that will be another way to explore that for some of the people who are more familiar with some of the old Right Care packs. So I'll just go through briefly some of these compartments, and you'll be able to sort of see what's in there. So within risk factors, we've got some lifestyle-based factors. So we've got obesity and smoking, and the percentage of physically inactive adults. So yeah, what we've got here is this is just a direct aggregate of so within the STP, that's 24.5% of adults are physically inactive. So that's based on the PHE, I think, Sport England survey. And you can see there that the national median is 20.7%. So that's why Birmingham and Solihull has been RAG rated as red. If you click onto the if you click onto the indicator, then if you scroll down, there's an understanding the data section, but also a data source there. So you can see that's taken from Public Health England based on the Active Lives Sport England survey, and then some further information within the methodology. So also another way to view that is to you can click straight onto the spine chart, and then that will bring up this interactive chart. So yeah, brings up the distribution chart. So each bar here is an STP, and you can see what the RAG rating is just based on above or below the median. So obviously, yeah, as we saw earlier, Birmingham and Solihull were at 24.5% compared to the median of 20%. But you can see from the distribution chart that that's actually the 5th highest value across the STPs for adults who are physically inactive. Okay, I'll just pause.
One of the questions was on how do we do a Midlands view, and there's the useful toggle on the top there that allows us to just highlight ones in a region. I'm not sure whether you can get that if you haven't got a national account. If you've only got one system, that might not be the best. I don't know whether you get that. But that will.
Yeah, so you can, as you say, you can change that toggle, and then you can just hover over, and it will show you which STP is which. And yeah, one of the things which you can also do, I'll just select a different indicator which will have this functionality in there. Sorry, selected another one that doesn't, but where we've got the CCG data loaded in, you can click to view that. I'm not quite sure why that's not coming up for that indicator. But yeah, in terms of so that's the sort of Midlands view. But yeah, what you can't do, as sort of we mentioned earlier, was to calculate
I'm on it side.
A Midlands
literally gone on for like
figure.
2 seconds. Probably should have been at the beginning because they're talking about something that I'm like, well, how have you got into that system? What is it?
All right, 1 second. There's one going on mute, just kind of conversation in the background. I'm trying to work out who we've got. Carry on, Bryn.
So, yeah, what you won't be able to do is to create a Midlands figure and compare that to other regions. But yeah, that's the view that you can create. Okay, are there any questions, Alex, or shall I carry on?
No, carry on.
Okay, then we've got a prevalence and detect. Sorry, it's a bit noisy background here, but so yeah, we've got reported prevalence, which is taken from QOF. So the quality and outcomes framework, trying to avoid the jargon buster questions. So what we have here again is an aggregate of the percentage in the STP for different conditions. So for example, for depression, we can see that 11.1% of adults within Birmingham and Solihull are registered on a GP register for having depression, and you can see that that's slightly below the national median of 11.5%. See, we've got that quite a range of conditions, and then underneath that we've got a smaller selection of those conditions where we've got estimated prevalence from Public Health England, and yeah, again you can see there we've got a percentage for the STP. You'll note that we haven't RAG rated the recorded prevalence, but we have RAG rated the estimated prevalence. The rationale behind that is that, yeah, so for example, if I pick one where Birmingham is higher, which doesn't seem to be very many actually, but this percentage of patients with diabetes where they're at 8.7%, what we don't know is if that's a true high value or could just be that the GPs in Birmingham and Solihull are very good at identifying and recording patients with diabetes. So that's why we don't RAG rate that indicator. Largely speaking, yeah, we would expect that to be quite reliable, but particularly within London and possibly some of the other cities, we do tend to see much lower recording than the estimated prevalence. And then, yeah, down at the bottom, we have a reported to estimated prevalence for each of those conditions where there is estimated prevalence from PHE. So we're just calculating a percentage, dividing the reported prevalence by the estimated prevalence. So this is saying that for coronary heart disease here, that Birmingham and Solihull have got, out of all of the estimated people to have coronary heart disease, that 60% of those are appearing on a register. And again, there you can see that that's lower than the national median of 68.7%. So that has been RAG rated. Whereas on diabetes, yeah, they're at 88.9%. So they're RAG rated as green. They're doing better at detecting and getting people on the register there for diabetes. Again, I'll just pause there and see if anyone's got any questions.
Yes, but Graham, do you want to come in and ask a question? Because I think it kind of relates to something Bryn's been doing with some new analysis in the mental health system team, looking at trying to do some pathway type indicators that might be quite useful. If you're able to come off mute, Diane, that'd be really useful to share that.
Yeah, hi. So that's really my question. In terms of care pathway work, I think it would be very useful to see how these things map into healthcare usage. And it's important because it tells us about access, not just, accessing services, but what is happening in primary care, what is happening in secondary care, and through to what is happening, even at the tertiary level. It's also important in addressing health inequalities it's important in identifying where you're going to put resources. So I think it would be very useful to join up the data. These discrete things are helpful, but if an ICS wants to make an impact, it needs to know that's the essence of population health management. You want to see what does it mean for my population on the ground, right through from primordial prevention through to tertiary prevention. So if you're telling me I've got very high smoking rates, what does smoking mean for my population? This is what it means for cardiac services. This is what it means. This is what I mean for cancer. This is what it means for a whole lot of other things, rather than there's just these discrete things comparing to other STPs. So that's where I would be interested in if I was in an ICS.
You're talking to very much converted with myself and Bryn here. We've been trying to do what we call pathways on the page for quite a while and look at things from a pathway approach. So very much trying to look at the data along a pathway from the prevalence in an area through to how well the management is in primary care through secondary care. So there are some compartment sections that Bryn will get to that actually show a lot of these metrics along more of a pathway approach. But we also have our right care focus packs and where to look packs that try and do that at a system level, CCG level. But then to get down to more of the inequality side, we've got some primary care network packs which allow to break down to much more of a local area, allow for the local variation in population and some of those inequalities to be more effective, and again have those pathway approach for each primary care network. So it's a really powerful approach. I'll show that very quickly at the end if we've not completely run out of time, but there's a lot to cover. So that's one thing. And I know, Bryn, I know you're trying to do some metrics.
Thanks very much.
That's okay. Bryn, do you want to say anything else about the kind of the tracking people through work as well?
Yeah. So, yeah, I mean, yeah, as Alex said, yeah, completely agree. And that's, yeah, what we're trying to do within right care and the pathway on a page approach. Within the linking, yeah, we're unfortunately, we're limited in terms of what we can do in terms of linking that QOF data with secondary care. Because, yeah, as you say, what we would really like to do is to link people from the register. So those that smoke, what do they have in terms of hospital usage compared to those that don't? And yeah, looking at out of those, out of all the hospital admissions for coronary heart disease, how many of those were for people on the register compared to those that weren't on the register, and yeah, which practices weren't doing well at getting people on the register and then having admissions. And similarly, yeah, in a lot of areas, looking at the drugs that they're on, and yeah, that's one thing that we might be able to do more quickly than linking to the QOF data, because the prescribing data is coming into our National Clinical Data Repository. So it's all pseudonymized, but we would, in theory, be able to link that, subject to obviously the ethics approvals to do that. But yeah, that would allow us to do a little bit more powerful analysis to show, for example, these are the patients that have been on these drugs for coronary heart disease or COPD or asthma, and these are the hospital admissions that have been for those patients. So yeah, there's a huge amount that we would like to do, but we are unfortunately at a national level limited by that linking of data sets in a way that I think you're not as limited at a local level. There is the population health segmentation and the PAPI dashboard, which is in Viewpoint, which does sort of do a bit more in that space, but again, unfortunately, that segmentation is based on the hospital diagnosis rather than on that primary care register, which would be the ideal, would be that we'd have all of that information brought together. So that's probably quite a long-winded way of saying no, we don't have much, but yeah, hopefully that sort of explains why.
Thanks, Bryn. I think that's answered it. We've had a couple of other questions through, but I'll let you crack on. I'll come back to them later on if that's okay with those who've asked it. I'm sure we'll pick it up as we go through.
Great. Okay. Then the next compartment is the primary care clinical. So yeah, this is the quality and outcomes framework data again. We've got some of those public health indicators repeated, but then we've got a range of indicators for the different disease or conditions. So yeah, if I scroll down to example,
This is data from the QOF return collected every March. So someone's asking how frequently these are updated. You can see there's a data period column. So this is March 2020 data. And Ian's asked about exception rates as well. So we put the exceptions back in, and I think there's a breakdown that shows you the reason for exclusion.
Yeah, so if I click on that arrow, then it's got what's either called child or indented indicators. So yeah, the exceptions have now been renamed as PCAs, which I'm afraid I can't remember the acronym, but I think it's yeah, that would probably be in the or hopefully will be in the understanding the data section, if I can.
What do you tell us on the chat before we get there?
Okay.
It says at the top of the thing,
personalized care adjustment. Yeah. So, but yeah, I think it's essentially, I think that is the exactly the same thing as the exception rate. So yeah, that shows you what that is. So yeah, useful to look at that alongside that. So sorry if I find my way back to that indicator. So if I click onto this, yeah. So what this? So it's if any clinicians on the call may want to correct me, but I think essentially this is patients who are at high risk of stroke, and are they currently on anticoagulation therapy. So obviously it's RAG rated that a low value is bad and a high value is good and rated green. So we'd want those high risk patients to be being anticoagulated. And you can see there that Birmingham and Solihull is the lowest, with 83.5% of those patients on the anticoagulation therapy, and 91% up in Lincolnshire.
We have just had a question about showing the table view on that one, so we can see the data. So you can actually hit export on that one if you want to produce your own charts. That gives you a list. It's quite an easy way of getting the information.
Yeah.
What we can't do, I don't think yet, Bryn, is do one of the charts that annotates all the systems on a graph straight away, which is a bit frustrating for somebody who works in a regional setting. But the export option's there if we need it.
Yeah. Okay, so yeah, there's a huge range of QOF indicators. So yeah, I won't go through them all, but yeah, there are some sort of key ones within that will be particularly important. And as Alex mentioned earlier, we've got our pathways on a page which do bring those out for those different pathways or conditions. And then, as shown earlier, we've also got the relevant clinical subcompartments such as cancer, which also pull out those key metrics as well. Shall I move on, Alex? There's more. So we've also in development, we've got a primary care access and satisfaction subcompartment, which is going to include information on the number of GP appointments, but also information from the GP patient survey about access and satisfaction. So that will be added shortly. But we've got the primary care prescribed. So we've got the items prescribed and the net ingredient cost, and we've got that for those high level program categories, which I don't think I explained earlier, but they're based on the World Health Organization's international classification of diseases. So they're a grouping of those. Within secondary care, the primary diagnosis codes, and within prescribing based on the drugs, there's a mapping of drug to program category. The presentation for this is slightly different to what we've seen so far. We don't just present an aggregate spend per 100,000 population, and the reason we don't do that is because some of the need, the demand for different conditions is very dependent on deprivation. So, for example, diabetes, we would, the expenditure on primary care prescribing drugs for diabetes will be very heavily linked to deprivation. So the approach we take is we only compare CCGs to their 10 most demographically similar, based on characteristics such as deprivation and age and ethnicity and rurality. So the approach that we take at STP level is to calculate a difference compared to the average of their similar 10 CCGs for each CCG, and then to aggregate that up to STP level. So if I choose this indicator here for circulation, so this is the coronary heart disease and stroke and problems of rhythm and other circulatory diseases. So yeah, over on the left hand side we've got those that are spending less per head of population compared to their demographic peers, and you can see there that Birmingham and Solihull is the lowest of the STPs, and then obviously over here these are the STPs that are spending the most. We also have an indented metric for these, so that was the items rather than the spend. I'll just scroll down to just show you that they should correspond, if I can find the circulation indicator. So there it is. So yeah, this system value here is saying that they're actually quite a bit higher in terms of spend than they were in items prescribed. You can see there they're much closer to the average. So that's, yeah, sometimes it is useful to look at both the items and the cost. So what we have got in as an indented indicator is that you can just click on that, and that will convert that difference per 100,000 population into something that's applied to the STP population. So this top one is saying that Birmingham and Solihull spends £407 per 100,000 population less, which so comes out at £470,000 less within the year, whereas for gastrointestinal, then that's 2.57 million less is being spent on gastrointestinal medicine compared to those demographic peers. So yeah, that's hopefully makes sense why we've gone for that difference in rate, and that. But I'll just pause there to see if there's any questions.
The chat's been very quiet. Anybody else has any questions on prescribing?
Not necessarily a question, Alex, but it's just a comment. It's Ian. As just to kind of say, as we would as ex-right care delivery partners, is not just to look at the data in those kind of silo areas. So there might have been a lot less being spent on prescribing on gastro for that area, but you need to look at the whole picture, and you need to look at what's going on with your elective care, your variation in elective care against the same peers, and your variation in non-elective care across those peers to get a full picture and understanding of why that prescribing figure might be so low. And it might not be a good thing.
Yeah.
The thing that's with it. So, you know, just because someone's spending less might not always be the best thing for the health of the population. So it's trying to take all those things into context.
Absolutely, Ian. Thank you very much. And yeah, you reminded me that I neglected one key bit of information there, that we have not rag rated this information for exactly the reasons that that Ian's just said. So yeah, we're not saying there that that Birmingham Solihull is doing well on gastrointestinal, and yeah, you would need to look at that alongside, well, in most cases the prevalence and the QOF data and the admissions data and the mortality data. I mean, in this instance, I don't think we've got a huge amount in terms of QOF or prevalence data for gastro, but certainly to look alongside the admissions and the outpatients and the mortality rates. And again, yeah, we'll come on to the pathways on a page in the right care packs at the end. With the gastro compartment isn't yet built, but within model health systems, that's another thing that's in development. But there is an endoscopy compartment, so that might be something that you might want to review as well. Yeah, but the full gastro information isn't on there at present. Okay, so I'm conscious of time. I'll quickly show the inpatients. However, it's in a very similar format. Hopefully it won't take particularly long, but yeah, if I've selected non-elective inpatients here, and similarly to the prescribing where we had the items and the net ingredient cost, we've got information on admissions and bed days and spend or tariff weighted activity. So yeah, just applying that unit price or to each unit of activity to turn that into a pounds figure. So we were looking at gastrointestinal before, and what Birmingham and Solihull had a very low rate. So I was looking to see if they had a very high rate of non-elective admissions, but that doesn't seem to be, well, that isn't the case. So certainly it wasn't for 2019. So you can see there that they're also lower spenders on gastrointestinal admissions for to hospital non-elective. So yeah, the format of this is obviously very similar to the prescribing data, but we do rag rate these non-elective admissions, and again we've got the indented indicators there, so you can see what that is in terms of patients or bed days or pounds. Yeah, it's just, again, I'm conscious of time, but I'll just quickly highlight some of the other areas. So outpatient attendances, again, is in a very similar vein to inpatients, that we present this as a difference in rates per patient. Though that this is done at treatment function rather than diagnosis level, which obviously isn't available for outpatient data. So this is just listed by the largest, I think, 20 treatment function codes. You'll see we've done some groupings of adult and pediatric, but otherwise, yeah, that's just a simple treatment function code split. Again, we've got the time series activity there, but we've got a couple of other indicators. So we've got the percentage of attendances that are new. So yeah, obviously similar to the first to follow up rate. So we've got that indicator, and we've also got percentage of attendances discharged after first attendance. So the rationale being here that a high value might indicate that that the system isn't doing as well at preventing referrals that aren't necessary and that would be discharged straight away. We haven't rag rated this one though, because there's there is somewhat an element of consistency of coding across organizations. So for example, we are aware that some organizations, or at least one organization, does tend to record people as to be treated at a later date rather than discharged. So they've got a very low percentage of patients discharged, but that doesn't necessarily reflect that their primary care is filtering out all inappropriate referrals. So yeah, that's the rationale for that indicator. So again, I'll pause there, Alex, see if there's any questions on any of that.
Yeah, Nick, I was just asked a very common question on virtual appointments and the change that might have had as a result of COVID. I thought I saw a metric around this somewhere.
Yeah, we haven't included it in the compartment because there is an outpatients compartment, which I will go to and show you that. So yeah, there's a range of information in here, both from the sit reps and from the SUS data. Yeah, the difference is that this is aggregated up from a provider level. So based on the providers that are located within the STP, whereas what I've been showing you in population health is aggregated up from the registered population. So yeah, we haven't included that percentage virtual, as we didn't want to sort of create a confusion by having two different methodologies or two different figures for that. But there, yeah, that is available there within that outpatients compartment.
Thank you, Bryn. I've got a question yet.
Anything else, Alex?
Kind of a split by speciality on the virtual one. I think the data can be. I'm not sure.
Yes, it can. Yeah, there's again a indented arrow drop down that you can click. And again, that's thinking often mirrored through into the individual clinical compartments as well.
Thank you.
Okay, then yeah, referral to treatment. So this is another one where there's a main referral to treatment compartment. So what we've included here, different again, just to sort of avoid duplicating in indicators. Sorry, my screen seems to have gone blank. Try reloading that. So yeah, we've got a slightly different indicators again to avoid that problem that I've just described. The out data being aggregated up from basis or CCG basis, the population basis. So what we've got in here is the waiting list per 100,000 population. So again, we've got that overall, and then by specialty, and then we've also got indented metrics for the clock starts and the clock stops per 100,000 population as well. And you can see there that we've got a time series as well. One functionality that I'm aware I haven't shown yet is that if you go into the interactive chart and select the chart type in the top right-hand corner, you can choose a variation or a trend line. And for some, there's also the options of scatter plots and SPC charts and funnel plots. But yeah, you can just, that's a different view that you'll be able to get if you go into that chart. So yeah, we've got the waiting list per 100,000 population. We've got the percentage of patients waiting less than 18 weeks. Again, we've got indented metrics there to show the numerator and the denominator, and you can view the time series chart for both of those. And then we've got the 52-week waits as well. We're also looking at creating some additional metrics based on the average, the median weights as well. So yeah, as I say, this is all still a work in progress as well. And then yeah, we've also got diagnostic waiting times which yeah, similar set information, but obviously for those diagnostic tests and the waiting more than 6 weeks for those tests. Again, I'll pause there, Alex, see if there's any questions.
No, I think you're answering them proactively now. Tom Frost, how can we request a new risk factor indicator to this, please? What do you mean by that, Tom? Do you want to come off mute? I'm not quite sure what you're referring to.
Hi, yeah. Sorry, I have my mic in the air. Hi, thank you for bringing me in. Yes, I was wondering if other risk factors, say around obesity or other things that are in the PHE fingertips tools, could be incorporated in here. And if so, is there a way that they can be requested?
Yes, so yeah, this is still work in progress, and we are bringing others in. So in terms of way they could be requested, that's a good question. There is a direct feedback form within Model Health System, which I think if I scroll down, there's a support section there, and then you can, it sort of opens up a new tab, and you can give we've still got the old lines actually, but the clinical service lines, this does need updating. I noticed that earlier, but yeah, you can submit. If I just click on this, you can submit a sort of suggestion request, and you can see here that you can view what other people have requested and voted on. So yeah, here sort of include agency staff when calculating the cost per weighted activity unit. It's got 15 votes. So yeah, you can submit it sort of directly from the system, or yeah, you can just either let Alex know, who can feed it into us. But yeah, as I say, we are working on that as well. So particularly alcohol. I mean, we do have the obesity in there from the QOF data in that risk factors section. I'm not sure is there a different indicator on fingertips?
Yeah, I think there's a Sport England active people survey version as well, probably from the same source as the physically inactive adults.
Yeah, so I think we'll have taken the view there that we've just included the one, and thinking that
is there a list of what you're going to include, so that I don't request stuff you already got covered?
Well, there is, but I mean, there's different people working on different compartments. So
okay.
Yeah, I mean, we could share that, but yeah, I mean, often what we might be doing is including something in one compartment and not another. So I think it's probably worth just sending through what you think should be included anyway, because that can influence our.
If I can email you maybe off this call, then
yeah,
be interested in discussing that.
Yeah.
Okay, brilliant. Thank you.
Just conscious of time, but is there anything else we want to cover on the population health section specifically?
Well, I won't really cover it, but just to highlight, there's mortality data in there and A&E attendances. So yeah, at the moment this is very sparse. We've just got the attendance rate again per 100,000 population, difference in rate, but we are looking into other indicators, including sort of people who've attended more than 10 or 15 times in a year, and looking at breaking that down by the diagnosis codes, just exploring the data quality. So and yeah, so some of the information around weights, etc. So yeah, that's still very much a work in progress, but just to make people aware that we've got something in there. But again, more will be coming. But yeah, we haven't bottomed out exactly what that will be.
Thank you.
So probably covers everything in population health. I mean, as I've mentioned, we do have other compartments which are a much more detailed view. So Alex, I'm not sure sort of what you've got in mind for the rest of the time.
So we've got some questions about PLIX data, which is more acute hospital focused cost data. So there's a whole hour's worth of stuff to talk about around that one, Liz. So yes, there is lots of data about PLIX from PLIX. All of the model health hospital data is based on PLIX, which it kind of comes up with their cost per unit of activity. So it's probably a bit too much to cover for that particular one, but there's more. I think there's actually earlier today. There's more general model hospital intro. So maybe we can need to have a chat about how we can use that specific data, Liz. If you send me an email, I can take you through some of that. Do you want to show perhaps the respiratory section is probably the most new one, isn't it?
Yeah.
And then just to show how the structure, and there's a few other areas that kind of fit into the similar pattern.
Yeah.
And then I'll show quickly the right care pathways and the primary care network bit.
Yeah.
And then there's one question just saying this around John Britton's A&E metrics from Liz. I'm not really aware what they are, Liz. Are you aware of them, Bryn?
Well, not specifically around A&E, but we are working very closely with John, and we've got some. We're jointly producing some inequalities indicators, looking at deprivation and ethnicity, or some key procedures, which has been aligned to the pathway work that's going on. So sort of hip and knee replacements within MSK, cataracts for eye care. But yeah, we're aware that John has got a range of other metrics, including the absolute gradient of inequality for ambulatory care sensitive conditions. So yeah, again, in due course, we will be sort of bringing that information in as well.
Thanks, Bryn. It was that the latter one. It's the priority ward stuff that would be really good. So good to know it's in the plan.
Yeah. So John's sort of covering a few other areas as well. So I think there's just some conversations ongoing with the relevant sort of clinical teams there around sort of what's sort of ready to be included. But yeah, we will be bringing in some information on that as well. Okay, so yeah, so within respiratory, again, we've picked the headline indicators, which you can see there, but I won't go through those. So we've got an all respiratory section, and then some compartments for what, again, previous pathways on a page we've had for asthma, COPD, and flu and pneumonia. So yeah, again, we've got some of the risk factors, which are sort of just mirrored in from population health. In fact, probably all of them, I think, maybe mirrored in from population health. So they're the same as we've already seen. Primary care prescribing, again, this is similar. So these top two indicators are again mirrored in from population health. But then we've got some of the more granular detail for asthma, obstructive airways disease, and then a specific indicator on the inhaled corticosteroids. So again, that's all similar formats, probably don't need to go into. Again, the outpatient data is all just mirrored in from that population health compartment and this inpatient section. But then down at the bottom, we've got a series of more granular information based on the groupings of diagnostic codes. What we don't have yet is procedure level information. We are doing some work with GIRFT to look at producing some of the procedure level information on a population basis, and also about including some population information in their GIRFT gateway as well. And then yeah, within the subcompartments, we've got some more granular information. So within flu and pneumonia, we've got the vaccination information. So again, sort of as I think, well, Ian and others were saying earlier, this is sort of one of the ways that you can start to view things in a little bit more of a sort of coherent way. So you'll be able to sort of look at the performance on the vaccinations and compare that to the admissions and the spend on the flu and pneumonia. I've realised, I think one thing I didn't say earlier about the admissions was that this is age, sex standardised and then compared to the demographic peers. I think I might have missed that age, sex standardisation point out. So apologies for that. And then, yeah, we've got a breakdown by flu and by pneumonia, and then also by age that you can see there. And then, yeah, within the COPD compartment, again, you just sort of trying to bring it all together a bit more. We've got the prevalence, the risk factors, primary care, the QOF data, and then the inpatient admissions. I mentioned before the mortality rates. We've not got the full set of mortality in there, just the information that's published elsewhere. But again, in due course, we'll be doing some work to fill in those gaps where the mortality data isn't published elsewhere for condition groups like COPD. Again, that's probably sort of respiratory in a nutshell, but happy to take any questions.
All quiet, I think, Bryn. Can I ask which of the sections we've already got live then now? So we've got respiratory, is it UTI and... Sorry, I think you're on mute. I've lost you to the neighbour's dog. So ENT...
Sorry, I'd realised I'd muted myself as I was coughing and I hadn't unmuted. So yeah, sorry, we've got we've got cancer. Sorry, in the policy priorities section, we've got a cancer compartment. We've got evidence-based interventions. The pathway improvement programme will have eye care, musculoskeletal, and cardiac services, as well as UEC. And some overarching metrics. That's not fully populated yet. And then within these acute hospital services, so this is a mix of sort of the traditional inpatient data that's on model hospital, the GIRF data, and the population-based data. So some of those compartments have all three. So ophthalmology is an example there. So we've got the GIRF data, so and the GIRF questionnaire. So we've got day case rates and related indicators for cataracts, glaucoma, etc. And then we've got that same sort of information covered on a population basis. So yeah, the areas where we've got the population information in, we've got a couple of indicators in cardiothoracic surgery and ear, nose and throat. Gynecology is well populated, as is urology and ophthalmology. Obviously respiratory, and then orthopedic surgery has some key indicators in there, about a handful, and urinary tract infections as well. And then endoscopy as well, which is further down in the clinical support services. And yeah, there's a range of other in development as well, including gastro and neurology and mental health, which I know we'd said we'd come back to. Alex, I mean, I know I clicked on it earlier. Do you want me to show some of that information that's in Model Mental Health Trust?
Yes, please. That'd be really. Before we go on, though, we did have just a question on COVID data. So I know there's a COVID recovery section. Probably don't need to show it. There isn't much COVID data on here, and it's more about percentage of activity compared to previous years and some of the waiting times. Is there anything else in that COVID section to show, Bryn?
There's some diagnostic information in there. So yeah, as you say, it's really sort of focused on the recovery side, and yeah, that weekly and monthly data. So yeah, I'll click into it, but yeah, you can see you've got the weekly data. So yeah, it's very much sort of focused on on activity being turned back on post-COVID.
So I'd be interested to know more about your question, really. Pop something in the chat so we can try and see what else we can do in terms of benchmark data around COVID.
Okay, so I'll just select, tell you what, shall someone tell me a Midlands mental health trust is likely to have Nottingham?
Nottinghamshire, at the bottom.
That one at the bottom, yeah. Oh, sorry, it's not showing up because I'm in the COVID recovery section. That's why. So yeah, we've got a range of compartments here with provider-based data. So if I click into the acute mental health, so yeah, you can see the subcompartments for caseload and activity and staff productivity and inpatients. So I'll just click into caseload.
These indicate
so yeah, you can see
less population-based and more process-based metrics, but still useful.
Yeah, that's the case. And as I say, these are all being aggregated up to STP level as well, so you can get that view. I'll just very quickly switch to preview just so I can show you what's in development. Let's say quickly. So yeah, what you can see in preview is that we've got these lenses, so bringing in those other elements, so for ambulance, community and mental health. And you can see, yeah, we've got all of these subcompartments that were in that model mental health trust view, but we've also added a compartment for the pathways based. So yeah, as I say, we're adding common mental health disorders, SMI, and dementia initially. And yeah, so if I just click onto this, then you can see on the population basis, we've got we've got some of the demographics and QOF data, and then we've got some of the IAP data brought into here. So you can see it's a work in progress. We've just got 3 indicators brought in so far, but yeah, I thought it'd be useful to just show what is being planned on mental health.
Thank you, Bryn. There was a question about the learning disabilities section, what we covered in that one as well. If we could just jump to that one.
Yeah, so it's not an area I'm that familiar with. What's in what's in the learning disabilities section?
There was one.
Yeah, I've probably picked again. I've not picked a mental health. Just I thought that was. I'll go back to Nottingham. So. So yeah, it seems like similar information taken from the MHSDS. So yeah, average number of patients on caseload and some demographic or patient information and some length of time on caseload.
So I'd probably combine that with looking at something like fingertips and some kind of population type data on that one as well. That was of use to you. So I lost the original question on that one, so if anyone's coming, please do shout. Is there anything else on the model health system anybody wants to pick up quickly before we move on? Any indication on autism? I'm not sure, actually. We don't tend to collect much new data. I'm not sure. Bryn, you aware of anything on autism?
I'm not sure. No, there is a search functionality, so I can pop it in there. Oh, system seems to be failing me, I'm afraid. Yeah, so I'm going to hazard a guess at no, unless it's an indicator that's been named sneakily.
And Thelma, you're asking for the opportunities for improvement section. Is that specifically in mental health, or is that back at the system level, or can I ask what you were? Are you still with us, Thelma?
Yes, sorry, I'm still with you. I was trying to find the mute button. No, it's not around mental health. It was just, I just wanted to have a look and see what was in that section, in that drop down, to see the sorts of.
In the, sorry, did you say opportunities?
Oh, that's it. That's what you were showing at the top.
Yeah, it's a good starting point to go in, but it also kind of gives you some nice breakdowns by CCG or other categories. So probably Birmingham's not the best system to demonstrate this one because we've only got one CCG in Birmingham. If you choose, I don't know, Coventry, you might kind of give us more of a breakdown.
Yeah, I just wanted to have a look in to see the kind of information that was in there.
So this I find this quite a useful one if you go to one of the big CCG kind of bed day numbers or something, gives you a nice breakdown.
Yeah, so I mean there's a range there, but I'll go to I'll go for cardiovascular disease non-elective bed days. So yeah, what we've got in here is sort of basically the figures that were in the right care packs. So we've got a range. So the 0 is compared to the average of the similar 10 CCGs. So that's saying that all of the all of the CCGs within this STP have got lower than average bed days for non-elective CVD. And then the upper figure, that 4,000 bed days or 12 beds, is compared to the average of the lowest 5 of those similar 10 CCGs. So yeah, that's similar to sort of the figures. Well, yeah, that would be the figures that are presented in the right care packs for that indicator. You can see there that we've got a breakdown. So South Warwickshire has got a lower rate than the average of the similar 5. But Warwickshire and Coventry and Rugby are between the median and that sort of best quartile. And yeah, then you can see we've got the bed days per population, and then the benchmark that they'd of those best performers. So if Coventry was to deliver that 4,000 bed day reduction, then they'd move down from 7,911 bed days per 100,000 population to 7,494. And yeah, you can see we've got a breakdown by CCG, but also by the different clinical areas within this program category. So yeah, again, you can click on that and see the CCG breakdown. So yeah, probably not the best example with them being low bed days on this anyway. Actually helpful there to see that Warwickshire, South Warwickshire, which did have no opportunity overall, sort of hidden within that, they do have an opportunity for stroke. So they could save 2,000 bed days if they moved down to the lowest 5 rate, or 930 bed days if they moved down to the average of their similar 10 for stroke.
So there's a lot to explore in the opportunities section. So in terms of ways of presenting things, and the bed day stuff's quite interesting, and some nice presentation of data from different types of plots. So yeah, worth an explore.
Thank you very much.
That's okay. I'm gonna, just conscious of time, Bryn, it's probably worth spending a minute or so to show the where to look pathways and the pathways on the page and the new PCN ones, because people might not be familiar with that. And we've had a few questions about PCN data. And I think I'd reply to somebody who says that PCN data will be available hopefully at some point on the model health system, but it's not guaranteed at the moment, is that?
No, it's not. It's not there yet. Yeah, it is on the development backlog. So yeah, I don't have timescales at the moment for that, but yeah, the data is processed. It's just waiting for the sort of system to be developed further. As I say, it's obviously a lot to be done, sort of expanding that from model hospital to model health system. So yeah, so this is the where to look pack. So this just around, well, I think it's the first alphabetical CCG, which is why it's Barking and Dagenham that happen to have it open. But so yeah, those familiar. So these used to be produced as a PDF. They're now produced as an Explorer file. So produced at CCG and STP level. This is obviously the CCG example, and you can either scroll through as you would in a PDF, or you can click through into any of these sections. So you can click to see the opportunity charts. So how different are we on detection? So this CCG has an opportunity to improve on, particularly on bowel cancer screening. But I'll just quickly show the pathways in a page because we've referenced those a few times. So yeah, you can see down the left-hand side, we've got the list of conditions that are covered by a pathway in a page. I'll select the heart disease one because we've sort of touched on some of that already. So this needs an update actually, because this version doesn't have the reported to estimated prevalence that I've just shown you in model health system. So we can rerun these now that's processed. But what it does is show all of the indicators on one page, or the key indicators. So to try and read across everything, as we've sort of mentioned a few times. So yeah, the bar shows the difference from the average of the similar 10 CCGs. So this CCG has got 20% lower recorded prevalence of coronary heart disease and sort of 30% higher recorded prevalence of obesity. Similarly to model health systems, some indicators we RAG rate and some we don't. So prescribing and outpatients and elective activity, we don't RAG rate. So yeah, as Ian said earlier, a low value for primary care prescribing might be a good thing, but it might reflect that they're not picking up enough patients and treating accordingly. But we do RAG rate the non-elective admissions and obviously the mortality rates. So for this example, this CCG has got lower recorded prevalence, slightly better on the QOF data, lower prescribing and elective and non-elective admissions, and although not statistically significantly different, lower mortality rate for coronary heart disease. So yeah, hopefully that gives a flavour for the sort of way that we present that. And then we've mentioned Viewpoint. This is again very much in development, but there is a Viewpoint dashboard for right care that's going to be developed, and that's going to be expanded to cover the primary care network level packs that we've discussed previously as well. Yeah, very conscious that we're time up, so I'll stop talking now.
Thank you. But the only thing I was going to throw onto that was the PCN pack. So I'm going to share on screen very, very quickly, because your team does wonderful work on this one, which is these very, very fantastic primary care network packs that you can summarise with these CCG pathways on the page. So we can see again the CCG shows all the primary care networks for heart disease, and it kind of colour rates whether they're above or below peers on those same pathways, and you can get down to the individual primary care networks and get a similar view on the pathway on a page at primary care network level. And these packs are incredibly comprehensive primary care network level. All the measures are in there. They rank each PCN versus their similar group of 20 primary care networks to show where they are ranked nationally out of all the primary care networks on a huge range of metrics. Really, really useful. It's a long pack, so 150 pages long, so probably can't really do it justice now, but vast amount of data. It all kind of links up. It's the same definitions as you've seen all the way through. Looks at things off from QOF through to kind of admissions and non-elective bed days and activity data and spend. So very kind of useful data to see if there's difference and really break it down to the lowest level you need to. But I'll stop there because we are completely run out of time, and I think we've hopefully not kind of crashed too much into your detail, your day. We've kept 50 people, so we've done well. We've recorded it, so people can catch up. How do you access them? If you register to my Midlands and East Right Care group, so that's at Future NHS, search for Right Care Midlands and East or Right Care ME. There's a link to it on there in terms of resources through to the primary care network packs. And there's also a Right Care Primary Care Network Where to Look pack network as well, which will give you direct access to all the packs. If you click request to join, I think there's a link somewhere when you click on that group. If not, go contact the Workspace Manager or email me or email Holly Davis directly, and we'll make sure you're added as soon as possible. And I think that's it. I think we can stop. Unless there's any last questions. The question on timing. I think we're updating these things as soon as we can do. So 1920 is probably the latest data we can release for a while, given the COVID data. Bryn, have you got any thoughts on when we're expecting Where to Look refreshes? Potentially October this year, but I'm not sure it'll be reliable, is it?
Well, we'll probably do it quicker. I mean, as mentioned, the COVID comparisons are, not ideal, but I think we will probably do them sooner rather than later anyway, and just trying to encourage people to look at the COVID comparison indicators we've got. So probably the primary care is less affected, so we could do the prescribing data, but sort of June time we would get that 2020-21 data for prescribing, and then we could do the SUS indicators shortly afterwards.
Thanks, Bryn. Can't see any more questions on the pack, so Bryn, on the chat. So if anyone else wants to jump in, now is probably your last time, but I'll just say thank you, Bryn. That's really helpful, very, very comprehensive as always, and useful to see what we've got. I hope some really good progress on there, so thanks to the team. We'll definitely share around a link to the different packs and resources. I'll share on the video so you can watch this back and show your children and have a lot of fun. But thank you all very much. And I'll let you all crack on with the afternoon and school runs and whatever you need to do. So thank you, Bryn.
Yeah, thank you all, and thank you, Alex, for organising. Thank you.
Thank you. Thank you. Bye.
Bye.
Thank you. Bye.